Okay, so we should wait for people to come in before we start. Okay, so I'm sharing my screen now, and so that we can start quickly. Sure that people have entered, and so I'm gonna share my screen now. So can you guys see my screen now? Okay, so yeah, and so we're gonna continue from where we stopped yesterday. I was talking about the pharyngeal apparatus, right? Pharyngeal apparatus, right? And so I talked about the clefts, I talked about the arch, and I talked about the palate, right? And so we're going to talk about each and every one of them individually. And so the first one I'm going to start with basically, the first one I'm going to talk about basically is the pharyngeal arch. So let me just talk about that quickly, right? And you know that I said that the cleft is derived from the ectoderm, the arch is from the mesoderm, and then the pouch forms the endoderm, right? Or comes from the endoderm. So the pouch comes from the endoderm. The arch comes from the mesoderm, and then the cleft comes from the ectoderm. And so we're just going to talk about each and every one of them. I'm going to start with the with the pharyngeal pouch. So the endoderm first. And so the pouch basically has four part of it. It has four parts of it basically. You have the first, second, and third and fourth part. And so there's a mnemonics I want you guys to remember. The mnemonics is called tap titus. Tap right titus. Right. So we have one, we have two, we have three, four, we have five, six, seven, eight. And so the first pharyngeal arch, like first pharyngeal pouch rather, gives rise to two structures. Firstly, the tympanic membrane, more like the lining of the tympanic membrane, rather, or the lining of the tympanic cavity. That's more appropriate. Tympanic cavity, and it also gives rise to the auditory canal, right? So this pharyngeal pouch, the first one gives rise to this TA. So let's label it as number one, right? And then number two, second pouch, gives rise to the pharyngeal tonsils, gives rise to the pharyngeal tonsils, tonsils, and then it also gives rise to the tonsillar fossa, tonsillar, tonsillar. So basically, structures that are found in the pharyngeal regions. Uh, what's lining it basically is derived from the second pouch, and then the third pouch. So when you look at this, our mnemonics, the second pharyngeal pouch is the PT, right? Second. The first is the tympanic cavity and the auditory canal. That's the TA. The second pouch gives rise to the pharyngeal tonsil, the pharyngeal tonsils, and then the tonsillar fossa. And then the third is this IT. So how I remember it basically for the third is that the third is kind of tricky because it has kind of like it kind of like how do I put this now? It has a kind of like different parts. And so it has a ventral and dorsal part. The third pouch has a ventral and dorsal part. So this is the dorsal part, or some people say the superior and the inferior, right? Superior and the inferior, the dorsal or the ventral part. Anyone basically, anyone goes. And so this guy, the superior part of the third pouch forms the inferior parathyroid gland. So let me just write PTH gland. So how you remember it is that the third superior forms the inferior parathyroid gland, and then the inferior part of this third pouch gives rise to the thymus, right? And then the fourth part. So when we go back to this mnemonics, you can see that the IT is the third part, right? And then this guy, the US, basically, we have the superior and then the inferior part, superior, inferior, right? And then the inferior gives rise to the superior parathyroid gland, superior PTH gland, right? Superior PTH gland. And then the superior gives rise to what we call the ultimo brachial, right? The ultimo brachial body. And this ultimobrachial body is what gives rise to the parafollicular cells. The parafollicular cells are the cells that kind of like tone down the level of calcium. So they reduce the level of calcium in the blood because the parafollicular cells secrete calcitonin. And then the parathyroid gland secretes parathyroid hormone. Parathyroid hormone kind of like raises the level of calcium in the blood. And then calcitonin does the opposite. And so this is the pharyngeal pouch. Once you remember tap titles, very easy to remember. All right. And so you can just arrange it basically in your head, like the D, V, D, something like that. You know, like, kind of makes sense. Dorsal ventral, dorsal ventral. But the best way to remember it's superior and inferior. I think that's the best way. That's how it comes. Yeah, that's the way I remember it to make it easy. And so this guy contributes to the fourth pharyngeal pouch, right? For pharyngeal patch. So this is a lot. This is just a summarized way of kind of like remembering it. So when you remember type titles, I think you can remember what each pouch gives rise to, and you know that it comes in pairs. So there are four pairs of each derivative, and it's a lot more easier for you to remember it like this. This is a mnemonics that is very, very common, and I used it and it was very, very helpful. So anytime you're stuck, because they test this in the exam. Now there's a clinical correlate that kind of like involves the third pharyngeal pouch, and it has to do with the thymus. And so there's a syndrome known as the George syndrome. So let me write that out. If you're doing immunology, you would see this syndrome, very, very popular syndrome. It's asked a lot in the steps, the George syndrome. And what basically happens here is that there's deletion of this chromosome, right? Deletion of 22p11, right? So there's deletion of this chromosome 22. And what this does basically is that the patient presents with a triad of kind of like three stuffs basically. So the patient has loss of the thymus. So the thymus doesn't develop, loss of the thymus. The patient has coro conotroncal abnormality. So this is like kind of like a heart, congenital heart disease, right? So congenital heart disease, conotroncal abnormalities means abnormalities that kind of like affects the bronchus arteriosus, you know. So abnormalities that affect that part of the child or the baby are known as conotroncal abnormalities. And the last but not the least is that the patient doesn't have a parathyroid gland, so there's loss of PTH gland. So it's very high yield. It's very important for you to know this, right? And these patients tend to also present with craniofacial abnormalities, cleft lip, cleft palate. They tend to present with it a lot. And so this syndrome is very high yield in the exam. Like it's extremely high yield. It's one of the most high yield concepts you need to know for immunology. And this is just a digression of that, right? And so, are there any kind of like questions here?
Excuse me, you said that the conotroncal abnormality means what?
So abnormalities that affect the truncus arteriosus of a child. So like
Okay,
the
thank
ventricular outflow, basically the ventricular outflow where you have the truncus arteriosus, and you know the septum that comes and kind of like divides it. You know that spiral membrane that comes and forms in the truncus arteriosus, kind of like partition the outlet of the heart. So abnormalities of that is known as chronotronchial abnormalities, and they tend to be common in patients with the George syndrome. Okay, so I don't know if that also makes sense to you. Then another thing we also have to know about this whole thing is the formation of the blood vessels, right? Um, so I'm just going to talk about the blood vessels and where they come from, basically. So let me just erase.
Doctor, could you do the fourth one again? What did you say
Yes,
the fourth one was?
the fourth one. I said the fourth one has a dorsal and ventral part. Oh, do you mean the for the DiGeorge syndrome?
No, for the pouch.
Okay, so for the pouch, it has a superior and inferior part, right? The inferior part gives rise to the superior parathyroid gland, and then the superior part of the fourth pouch gives rise to the ultimobrachial body. That guy differentiates further to have the parafollicular cells, and the parafollicular cells are the ones that kind of like secrete calcitonin. Yeah, so calcitonin kind of like tone down the amount of calcium in the body, right? So that's what happens with the fourth one. I don't know,
All
is
right,
that
thank you.
okay?
Yeah.
Great. So how I want you guys to remember it is that for the third pharyngeal pouch, the superior part gives rise to the inferior parathyroid gland, and then for the fourth pharyngeal pouch, the inferior part of the fourth pharyngeal pouch is what now gives rise to the superior. So it's kind of like opposite, right? For the third, the superior part gives rise to the inferior parathyroid gland, and then for the fourth, the inferior part gives rise to the superior parathyroid gland. Yeah, so that's how it is. And so, excuse me. So now let's go back to what I wanted to talk about. I wanted to talk about the arterial system, but before I go there, I want to talk about the pharyngeal like arches, right? The pharyngeal arches are the mesoderm part of it, the mesoderm part of it, right? So the pharyngeal arch. So this is the pharyngeal arch. This is the mesoderm part of it, right? And so we have the first, right? How I just want you to remember is that the first pharyngeal arch starts with anything that has to do with M, right? So it has everything to do with M, basically, is what it gives rise to. And now the pharyngeal arch gives rise to three things, basically, right? The pharyngeal arch gives rise to bone and cartilage. So the second as well, the same thing, bone and cartilage. The third, the same thing, bone and cartilage, just like that. That's what it gives rise to. And these things, although some of them can be tested in the exam, but not all of them, are usually like so much tested. But it's just good for you guys to know. And I'm not just going to dwell so much on it. I'm just going to talk about it, the first and the second, because there's a pathology that's kind of like associated with that, right? So basically, the first pharyngeal pouch gives rise to anything that contains M in it. And so the bones, so let me write bone here.
زحل بخیم پای ما کمک بشوی.
and then the cartilage, right?
یک چیز بانک ده. یک چیز عود داغ کتن salt. درد دارم.
Doctor, can you mute your mic, please?
درد دارم.
Okay.
Nigeria guy. هیچ نمیفهم گپشو.
Doc, your mic is unmuted. Hello, Dr. Maranga, your mic is unmuted. So the bone, let me go to the bone basically. So the first pharyngeal arch gives rise to, so how I remember these bones basically is when you think about the ear, right? You think about the ear, and then you're thinking about structures that that has to do a lot more with the ear and then the lower jaw, right? The ear and the lower jaw. So that's how I think of the bones that are involved here. So I think of the mandible. The mandible has an M in it, right? The malleus, which is part of the ossicle, has a bone in it, has an M in it, right? And also another thing that it has is the maxilla and the zygomatic process. So the maxilla also has an M in it, right? Another thing that it also has is what we call the Merkel's cartilage. The Merkel's cartilage includes the malleus and the incus. So you can just, kind of put it together as the Merkel's cartilage, right? Merkel's cartilage includes the malleus and the incus. So the mandible, the maxilla, the zygomatic bone, they're all gotten from the first pharyngeal arch, right? So, but what you need to remember is that anything that starts with an M, basically, I want you to think of the first pharyngeal arch. And so the muscle that's involved, so that's the muscle. This one that's the bone and cartilage that is formed, right? The muscle, of course, the mnemonics I used to remember it is MAT. So the M stands for muscle of mastication.
Sorry, I missed the fourth M, the one you wrote behind malleus.
Okay, so what I wrote was this is the maxilla, right? It gives rise, so it basically gives rise to any muscle that has an M in it, right? Any bone, cartilage, anything that has an M in it is what the first pharyngeal arch gives rise to. So the mandible, the Merkel's cartilage, the maxilla, and then the zygomatic bone. Those are all derivatives of the first pharyngeal arch, right? The Merkel's cartilage includes the malleus and the incus, the malleus and the incus. So combined together, I call them the Merkel's cartilage, right? The malleus, the incus, and the Merkel's cartilage. I think the Merkel's cartilage is kind of different. So just put it like this. We have like 4 derivatives of the first pharyngeal arch that gives rise to a bone or a cartilage. And this includes the maxilla, the mandible, the Merkel's cartilage, the malleus and incus, and then the zygomatic bone. So anything that has this zygomatic has an M in it, so that's also correct. The malleus has an M in it, the maxilla has an M in it, the mandible has an M in it. So all of them are like kind of M kind of things. M, all of them have M in them. Right? I don't know if that makes sense. Apart from the incus, all of them has M in them. So the M for the muscle, the M for the muscle is the muscle of mastication. So all the muscles of mastication are gotten from the first pharyngeal arch. So you have the lateral pterygoid, the medial pterygoid, the masseter, the temporalis. You can see that all these muscles tend to have an M in them. They're like, once you just think about the muscles, the first pharyngeal arch, the first thing I just want you to put in your mind is that it starts, almost all its derivatives has an M in it, the letter M. And then this A is the anterior digastric muscle, the anterior belly of the digastric muscle. So let me write that out for you. So this M here, so the mnemonics for the muscle is called MAT, the muscles that are gotten from the first pharyngeal arch. And how I remember it is that, remember all the muscles of mastication, then the A is the anterior belly of the digastric muscle, right? Anterior belly of the digastric muscle. And then the last one I remember is the tensor tympani. Tensor tympani. These muscles are derived from the first pharyngeal arch. The MAT muscles are derived from the first pharyngeal arch. The MAT muscles, please take note of that. The muscles of mastication, anterior belly of the digastric muscle, the tensor tympani. These muscles are derived from the first pharyngeal arch. So you can see that almost everything we're writing about these muscles, this cartilage, they have an M in them. They have an M basically. They don't have any other thing apart from an M, right? And so the second pharyngeal arch gives rise, and now the nerve that innervates, that kind of like follows, because every pharyngeal arch has a blood supply. It has a blood supply. It has a nerve supply, and so the blood supply to the first pharyngeal arch is the maxillary artery. The maxillary artery is a branch of the external carotid. The maxillary artery is a branch of the external carotid. And the nerve that follows these muscles is cranial nerve 5. So I've listed the muscles to you. I've listed the innervation, which is cranial nerve 5. I've also listed the blood supply to the muscles, which is the maxillary artery, right? So you need to know these things. They can kind of like twist this in the exam. So I want you guys to like kind of like just, it can be a bit confusing. It can be a bit confusing, but I'm just trying to simplify it for you guys so that you guys can have an idea of what it is. The second pharyngeal arch, the same thing, has a bone and has a muscle, right? It has a blood supply, and then it has nerve supply. The blood supply to these muscles that will come from the second pharyngeal arch includes the stapedial artery, and then another blood vessel that comes out very rare, but it obliterates. It's called the hyoidal artery. Hyoidal. It's not tested so much in the exam, so you don't really need to bother yourself. I'm just putting it here for putting's sake. So this guy obliterates, right? So in an adult, you won't see this blood vessel. It's actually a derivative of the internal carotid artery. The internal carotid artery, right? It's internal carotid artery. But it obliterates before the child is even born, so you don't see. So the main blood supply is the stapedial artery. And the nerve supply is cranial nerve 7. That's the facial nerve. So generally, the second pharyngeal arch supplies muscles that help with, the facial. They supply the facial muscles. And so the bones you expect to see here are bones that, kind of like reinforces the what do you call it now? Kind of like reinforces the muscles of the face, right? And so the bones you have here basically are the stapes. Yes, you have the stylohyoid, right? You have the stylohyoid, styloid horn. I think the lesser horn of the styloid process, lesser horn. Come here. This is a bit rough. So the stapes, which is an ossicle, is formed by the second. Then you have the lesser horn of the hyoid bone. Right? Another thing that we have here that you have to know is the stylohyoid ligament. So you can see all of them have an S in them. Stylohyoid ligament. Stylohyoid ligaments. So there are 3 structures that I want you guys to remember, and they are all S. So the stapes, the lesser horn of the hyoid bone, so you can see the lesser, the stylohyoid ligaments. All of them have the S. The bones and ligaments that derive from the second pharyngeal arch have the S in them, right? And so the muscle, the mnemonics I use for the muscle is known as mass. And of course, it also has an S. So this is kind of like, pass. I kind of like use this pass. I use not mass, pass. So I use pass as the mnemonics. This is a very boring part of reproduction. But I don't have a choice. I just have to explain it. So the pass is the posterior belly of the digastric muscle, posterior belly, right? And so the first S here is the stapedius. Stapedius muscle. This second S here is known as the stylohyoid muscle. Stylohyoid muscle. Stylohyoid muscle, right? Stylohyoid muscle. And then the A is the auricular muscles, the muscles of the ear, auricular, outer ears, auricular muscles. That's muscles that help with hearing. So demonics I just use is pass, right? To remember the second pharyngeal arch, right? The third is the easiest to remember. The third is so easy to remember. The third, basically, so the third you have here basically is the nerve, the vessel. The nerve here is cranial nerve 9. So the glossopharyngeal nerve. The blood vessel is kind of like complicated, and I want us to, like, when we get to the aortic arc derivatives, we'll talk more about it, right? Because it has two parts. Basically, the blood vessels to this side kind of like come from the carotid artery. Carotid artery. And so we have the common carotid and the internal carotid artery. And they come for, like, they're the ones that supply muscles of the third pharyngeal arch. And so the muscle here, very simple to remember, stylohyoid muscle, stylopharyngeus, sorry. Stylopharyngeus, very simple muscle to remember. The other thing you need to know is the greater horn of the digastric. The greater horn of the hyoid. So this is like the bone. This is the muscle, right? Greater horn of the hyoid, right? Now, the reason why I was trying to explain this thing is because the part 1 and part 2, I was particularly very took my time to explain is because there's a kind of like syndrome that affects a syndrome and a sequence that kind of like affects the second failure of the second and the first pharyngeal arch to kind of like develop. And the first syndrome basically is known as the Treacher-Collins syndrome. Treacher-Collins syndrome. You see it in first aid where they put it by the side, where the patient basically has neural crest cell dysfunction basically. So a lot of things are not working basically. They have craniofacial abnormalities, they have hearing loss, they have airway compromise, because the cranial nerve, which kind of like is involved in kind of like making some craniofacial structures, is actually absent, and so they come down with airway compromise, they come down with hearing loss, and then they come down with and then they come down with neural crest dysfunction. That's one syndrome, Treacher-Collins. The other one is Pierre-Robin sequence. Pierre-Robin sequence basically is affects more of the first pharyngeal arch. It also affects the second, but most commonly the first. And so the patient has what we call glossoptosis. So the tongue is kind of like the mouth is small. The mouth of the patient is small, so it kind of like gives this. The tongue occupies a very wide amount of the mouth, and so it gives this impression that the tongue is big, right? The tongue, the mouth, the jaws. Patient has small jaws, has airway compromise, and then he has this big tongue that seems as if it's big, but it's not actually big. It's just normal. It's just that the mouth is very, very small, right? The patient also has cleft lip. These are things you see in Pierre-Robin syndrome. It's also very high for you guys to know this. I've seen an MBME question on it. I think MBME 24, 25. I don't know. I think one of them. Okay, and so we're going to talk about this, basically the third, and so we're going to continue and talk about the fourth. Basically, the fourth gives rise to most of the pharyngeal constrictors, except one muscle. It gives rise to all. The fourth gives rise to all the pharyngeal constrictors. So we have the superior, the middle, and the inferior constrictors of the pharynx, and so the fourth gives rise to that. So the fourth gives rise to kind of like the constrictor muscles of the pharynx. It's a very, very long topic. All right. So I'm just going to stop at the fourth so that we can move ahead. There are a lot of things for us to cover. Constrictors of the pharynx, right? Constrictors of the pharynx, right? And then the sixth brachial arc kind of like gives rise to all the muscles of the larynx except the cricothyroid. So all the muscles of the larynx, right, is produced by the sixth pharyngeal arch, apart from the cricothyroid muscles. The fourth gives rise to all the constrictors of the pharynx. Constrictors of the pharynx. We have three. We have the superior, the middle, and the inferior constrictors of the pharynx. And then the sixth gives rise to all the muscles that help with like all the intrinsic muscles that are found in the larynx, except the cricothyroid muscle, right? And then the cartilage that the sixth kind of like gives rise to, I'm going to just have to explain this. It's called acts. Acts. And how I explain it is that I usually say, Irie, call Chris to talk and see. Irie, call Chris. Or Irie, call Chris to talk and see. And so I remember the Irie as arytenoid. I remember the cord as corniculate. Then Chris as the cricoid. And then I remember the T to talk. So let me write this out. So it's more easier for you guys to remember. This is the cartilage that derived from kind of like the sixth pharyngeal arch. The sixth pharyngeal arch, basically. Are you there, guys? Please just give me a minute. So where was I, guys? I was talking about the mnemonics for the sixth. So I remember it as acts. So this is A, C, C, C. Usually I put it C. Yeah. So talk and see. So arytenoid. So the arytenoid is called Irie, call. So I call this call like call, right? So this is the corniculate. And then I say this is called the cricoid. So I call it Chris like cricoid cartilage. And then this guy is called the thyroid cartilage. So yeah, and then the last C is called the cuneiform. So the cuneiform. So the mnemonics is called Irie, call Chris to talk and see. So the C is like cuneiform, like cuneiform cartilage. And so that's how I remember it, right? So I wanted to talk about the arterial blood supply, but I would have to like leave that for later in cardiology. In cardiology, we'll talk more about it. I don't know if they have discussed that with you guys. I wanted to talk the arterial blood supply, but cardiology would have been a better way to explain how the aorta is formed. I'll have to leave that for cardiology.
You finished cardiology already.
Oh yeah, finished cardiology. Did they teach you guys about how the aorta is derived or the aortic derivations?
I can't say. I'm not sure.
Ah. Okay, so it means that I have to take this. I have to take this since you guys will not talk about.
Doc, could you please go through the blood supply and nerve of the first arc again?
Yeah, so let me go up. I don't know if I've erased it. Okay, the blood supply of the So the nerve supply to the first pharyngeal arch basically is the trigeminal nerve. So it's a cranial nerve 5. So cranial nerve 5 is responsible for the nerve supply to the first pharyngeal arch, right? And then the blood supply to this blood vessel here is called the maxillary artery. Right, I don't know if that's clear. So cranial nerve 4 supplies it. Yeah. How do I do this now? I wanted to like kind of like explain the blood supply to the how the aorta is derived. Okay, let me just see. Maybe since we're having reproduction, I might. We're still in reproduction. I will explain that. I will explain it. Dr. Raina, I will explain that blood, how the aorta is derived. I will explain it for you guys. Let me just try and see how far I can go first. So the clinical correlate basically behind all this is why are we learning all of this basically is to know they can test you guys in a lot of ways. There are some people who might be lucky and get a lot of reproduction questions on the day of their exams. And so these things that I'm telling you might come in a bit handy, right? So that's why I want you guys to kind of like get the info, right? I'm going to explain that aortic derivation for you guys. I'm going to explain it. Don't worry. So the next thing I'm going to talk about is cleft lip and cleft palate, right? And so let me just try and explain this with first aid. So because it makes more sense with first aid than drawing it, right? So what you have in the cleft lip is that there is fusion of the So let me go to this picture and try and explain. So this yellow, golden yellow stuff you are seeing is known as the maxillary process, right? These two. And so basically what happens in cleft lip is that this nasal, so let me draw it like this. Let me explain it. So you have this guy here, you have this guy here, then you have two small guys here, right? These guys are known as the median nasal prominence. Median nasal prominence. And this guy here is known as the maxillary prominence. Right, maxillary prominence. And so what happens is that these two guys fuse together to form what we call the intermaxillary segment. Intermaxillary segment. And what happens is that this intermaxillary segment is supposed to fuse with this guy here and this guy here. And so if there's a if this doesn't happen, this fusion doesn't happen, you have unilateral cleft palate. If both of them don't fuse, and then you have what we call bilateral cleft palate. Cleft lip rather, bilateral cleft lip. So if this guy is supposed to fuse first, and then these two guys are supposed to come and join him in the center. But a failure for either of them to kind of like join this middle guy in the center kind of leads to the cleft palate, right? The cleft lip. And then the cleft palate is just the opposite. So basically what happens here is that this nasal septum is supposed to fuse with these palatine shelves, lateral palatine shelves at the middle, right? This guy. And so the intermaxillary segment, this intermaxillary segment forms the primary palate, or like, yes, the primary palate. And then this palatine shelf and this nasal septum is supposed to form the secondary palate, right? That's what's supposed to happen there. And so cleft palate happens when this nasal septum, this guy in the middle here, doesn't fuse with these two nasal prominences, right? And so we go to the next thing I want to talk about, right? So I'm going to explain the embryology of the female and the male. Sorry. We're going to explain the embryology of the female and the male so that we can just get this. So what happens here basically, just to quickly just put this out there, is that for the female and the male, you know, I was talking to you guys about embryology the other day, and I was telling you guys that we cannot determine the sex of a fetus up until around the 8th week, right? The genitalia start forming at the 8th week. And then if you want to determine the sex, it's at 10 weeks that you're able to determine if it's a male or a female. However, you will not be able to know from an ultrasound scan until the 15th to 20th week. And so what happens basically is that there is a primordial, there's a primordial cell for the genitals, and it's known as the genital ridge or tubercle. So this starts around the 5th week, right? But becomes very prominent at the 8th week. So it starts at the 5th week, becomes prominent at the 8th week. And so at around the 10th week, what basically happens in this basically is if the default setting of all human beings were all meant to be females. I said that in the last class, default setting were supposed to be females. But what basically happens is that there's a mutated chromosome that the males kind of like give the females, and it's the Y chromosome. And then the Y chromosome has a gene called the SRY gene. And what this SRY gene basically does is that it kind of helps the proper differentiation of the male chromosomes. And so what it does basically is that the XY gene will do something very, very important, right? So this would cause the secretion of certain hormones, such as the will induce the Y chromosome, the X gene will induce the formation of a testes, right? So this genital ridge will become a testicle, thanks to this XRY gene. So it will go and influence this guy here to tell this guy, you know what, you are a guy, so you have to start forming testicles, right? And so we have two parts of the testicle, basically, or two major cells, basically, of the testicles. We have the Sertoli and we have the Leydig cells, right? This guy here secretes testosterone. This guy here secretes the Mullerian inhibiting hormone, right? Now, I want you guys to remember something. Let me take you guys to this picture. So now you can see that there are two ducts here. We have the paramesonephric duct and we have the mesonephric duct. And so what the Mullerian inhibiting hormone does basically is to kind of like, so there's a way to remember it, because this thing is very confusing in the exam. You don't know which is which. You don't know whether the para is for the male and the meso is for the female. And so how I remember this basically, what do I do? How do I solve this confusion, right? The word para means to stay by the side, right? And so if this is the mesonephric duct, the paramesonephric duct comes close to it. So it's like close to it, para, like the same axis, basically. And so how I remember this is that the normal thing that's supposed to happen is that when you get married to your wife as a man, right, or you're going down to church or you're in the mosque, you want to do your marriage, you usually have the man standing and then the woman is kind of like close to him or adjacent at the same plane. And so I remember the man as mesonephric. So I just changed the meso to mesonephric, and then the woman that is close, that is para to the man, is called para mesonephric. So another way to also remember it, because they kind of like confuse this thing a lot, the mesonephric duct is also known as the Wolffian duct, right? The Wolffian duct. So how I remember this basically is that, we have X-Men, the movie. And so one particular actor in the X-Men is known as Wolverine. And he's a guy. So I just kind of like put it together. Like the mesonephric duct is a Wolverine. Like a Wolverine. Like I don't know when it makes sense to you guys. That's how I remember it, right? And then the paramesonephric duct is close to it. So that's how I kind of like remember it. And instead of, you have what we call woo men. And so I just changed that woo to mu, Mullerian. Like the woo and the mu, I kind of like, I don't know if this makes sense, guys. This is how I kind of like remember it so I don't get confused in the exam. And so let's go back to this thing. So I was trying to say that the Mullerian inhibiting hormone kind of like goes tells the Mullerian duct, like, you know what, I don't want you guys to form. The Mullerian duct, which is the mesonephric duct, gives rise to the internal genitalia of the female. So it gives rise to the right. Okay, so before I get there, let me explain this, right? And so this guy induces the when the MIH, the Mullerian inhibiting hormone, is produced, the Mullerian inhibiting hormone goes to tell the Mullerian duct, like, look, you're no longer needed. You know, this guy needs to be a divorcee, or he needs to be a widow or something, widower or something. So the MIH goes and murders. So how I remember it is that the M stands for M. It goes to murder, you know, the woman. Like, I don't know if it makes sense. The MIH goes to murder the Mullerian duct. All of them have an M. So MIH murders the Mullerian duct, right? So the MIH that's secreted by the Sertoli cells comes, you know, goes to this guy, the Mullerian duct, and murders him, terminates him. And so the Wolffian duct is what remains. And the sad thing is that when he murders this guy, when he murders the Mullerian duct, it creates a remnant known as the appendix, known as the Gardner's duct. So the MIH murders the Mullerian duct and turns it to the Gardner's duct, right? That's the remnant of the paramesonephric duct, right? And so basically, what basically happens, this is what happens if the male, like, gonads are formed. And of course, the Wolffian duct gives rise to we call it the seed organs, right? Gives rise to the seed organs. So let me just explain what this means, right? The seed organs are the seminiferous tubules, the epididymis, you know, the ductus deferens, you know, those stuff basically. So it gives rise to them. The ejaculatory duct, more like the internal genitalia of the guy, right? That's what the Wolffian ducts do. But what happens if a female wants to be formed? So what happens in a female if the Y chromosome, does not secrete it's not present in the fetus, there's no SRY gene, and the normal stuff goes on. The baby becomes a female. And so what happens is that the Wolffian duct or the mesonephric duct degenerates, and then you have the two paramesonephric ducts together. So this is the ovaries. The primitive gonads become the ovaries, right? And then the paramesonephric duct fuses together to form, you know, like the womb, the proximal vagina, and the cervix. So it forms the upper part of the paramesonephric duct or the Mullerian duct now fuses together, and then apoptosis occurs in the middle to kind of get this full shape that you're seeing basically, right? So the paramesonephric duct gives rise to the ovaries, the fallopian tube, the body of the uterus, and the proximal part of the cervix. That's the paramesonephric duct, right? And so you need to know that. So what happens when the Wolffian duct does not form? It becomes what we call the appendix testis. The appendix testis. What they usually do, I think in first aid, the first aid Q&A, there's a question about this where they drew this structure. They drew this structure, right? And they now labeled it. They labeled it as A, they labeled it as B, they labeled it as C, labeled it as, you know, sort of like they labeled it, and then they now asked that the baby is a female, which structure degenerates. So it's very easy once you know that the structure closer to the gonads, the structure that is closer to these gonads is the mesonephric duct. So when it degenerates, this guy has to come and take over. So this guy also has to come and take over. When these two paramesonephric ducts degenerate, this guy has to come and take over. And when this guy takes over, right, it holds it. It's not able to suspend it. And so there are various ligaments that help to attach these ovaries that will be formed after this guy degenerates and this guy comes to. We'll talk about that in the anatomy when we get there, right? I just want to explain some certain things so that you guys can understand. And so basically, we can have various issues here, various pathological conditions here, right, that can happen. For the female, these two can fuse and cannot be properly resorpted. And so we can have three scenarios, basically. We can have a bicornate uterus. bicornate uterus, and we have the didelphi uterus, and then we have the septate uterus. So what happens is that when these two tubes fuse together, right? They fuse, like they literally fuse together like this. Right? They fuse together like this, right? And so basically there's supposed to be a resorption, like this side is supposed to like clean off. There's supposed to be resorption, right? Resorption, so that you can have the proper uterus that's like this, kind of like this, right? So, but what happens here is that this resorption does not occur. And when there's a failure of this resorption to occur, resorption of this septate, you have what we call a septate uterus. So, in the exam question, they don't usually, in the steps, they might not give you they might not give you a diagram of it. They might just do a HCG, HSG for you, put a dye, and you see the picture of each of them. So basically what happens is that the septate is somewhat like this, right? And the the bicornate is much deeper. While the didelphi is a lot deeper. So it's something like this. These are the didelphi is like the didelphi's uterus. So you just need to know, because they might put the HCG diagram for you, right? And it might show this guy, it might show the septate, it might show the bicarbonate. So you need to know how to differentiate both of them equally. So how you differentiate them is by the depth of the septate, the depth of the septate. So for the didelphys, the septate has the largest depth, the bicarbonate has the medium depth, and then the septate has a very low depth, right? And then another thing that can happen basically is the Mullerian agenesis. The Mullerian agenesis is where the paramesonephric dot does not even occur. So in that kind of situation, the patient will present with kind of like very awful symptoms. The patient will not be able to attain secondary level of secondary sexual characteristics because the ovaries are not there, the fallopian tube is not there, the cervix is not there. So in these patients, you will not see any of those organs, right? You will not see any of those organs. The patient will just have maybe a blinded pouch, and then have a vagina and a vulva. But the patient will have a cervix, won't have a uterus, won't have a fallopian tube, won't have ovaries, basically. And so that's what happens. That's the pathology I just want to explain to you guys here. I don't know, do you have any questions at this point? Are there any questions? Okay, so let's continue, right? So that's what I was trying to explain here. So this basically is just a summary of everything I'm saying. I'm not going to dwell on it. This is also what I was trying to tell you guys about the uterus. You can see the septate, you can see the depth, you can see that it's going lower and lower. You can see. So on the HSG, you're able to tell by the depth of the septate, basically the dividing barrier between both of them. And so these are derivatives of male and female homologous. So I'm just going to show you guys how to quickly recognize it. You can see the labiosacral swelling and the urogenital fold, right? So in the female, this labiosacral swelling forms the labium minora, the labium majora, and then this urogenital fold forms the labium minora. It's very visible here, you can see it. But for the male, this thing here forms the scrotum, and then this here forms the ventral penile shaft, right? Of course, the genital tubercle forms the gland penis and the penile shaft, basically. But what I want you guys to remember is here, right? I want you guys to note that anytime you see any gland, so there's greater vestibular gland, urethral and pituitary gland, bulbo urethral gland, prostate gland, anytime you see anything that has to do with gland, I want you guys to know that it comes from the urogenital sinus. So that's the shortcut I want to like tell you guys. So anytime you see in a question, they tell you the vestibular gland, the Cowper's gland, the skin gland, or whatever, any gland at all, the prostate, which is a gland, I want you guys to put at the back of your mind that all of them come for the urogenital sinus, because they twist this thing a lot in the exam. Urogenital sinus. So anything that has to do with gland comes from here. So anything that has to do with gland comes from the urogenital sinus, just like what I showed you guys here. You can see that the prostate gland, the urethral gland, the Bartholin's gland, the gland of skin, anything that has to do with gland at all comes from the urogenital sinus, right? And then the general tubercle gives rise to the corpus cavernosum and spongiosum, the vestibular bulb. You can see this is a bulb, it's not a gland. If it was a gland, it would most likely come from the urogenital sinus. So this is like a hack I used to remember it when I'm in the exam so that I don't get kind of like confused. And so there are pathologies that can happen in the male such that this urogenital fold fails to fuse. And in that situation, this ventral penile urethra will be exposed and you have hypospadias, right? And that's what happens here. Have hypospadias. But you can also have epispadias, and this kind of like happens when there's an abnormal. So the genital tubercle, this genital tubercle here has an abnormal opening. This opening you're supposed to see here comes to be at the dorsal part of it. This opening of the glans penis here kind of like comes to the dorsal part of the penis. And if that happens, the patient has epispadias. And you need to know the associations, right? The association with these things. That's also very high yield, right? You need to know the these associations, very important. This is also very high yield for the exam. Estrophy of the bladder, very common with epispadias. You need to know that for the exam, very high yield. There was a question. There's an MBME that I answered. And I was preparing for my exam. I think MBME 28. Yes, 28. That had this question. Yes, that had this particular question. Estrophy of the bladder and epispadias. Yeah, it had it. So I want you guys to remember that, right? It's kind of high yield. Gubernaculum is kind of like, so in the testes, when the test, like I told, let me go back to this diagram where I was telling you guys that this diagram, let me go back to it so that I can highlight something for you guys. So this is what I was trying to explain here. So you can see that I told you guys that this guy here forms the gonad, becomes the testes or the ovaries, right? And if you can see that the gubernaculum kind of like suspends, kind of like it's in between, like kind of like where the mesonephric duct, it is also there. So this is what kind of like attaches when the testis kind of like descends into the scrotum. This guy also follows it, this gubernaculum, but it becomes shrunken. It starts degenerating at the lower pole, the middle pole rather. This middle pole starts degenerating and becomes thinner, right? It becomes thinner and shrunken. And so it attaches this testicle to the floor of the scrotum in the penis. So let me just show you guys what it means basically. So this is, let's say this is the testis, right? This is the testis. And this is like the epididymis, right? And so the gubernaculum kind of like attaches this guy to the scrotum. So let's assume this is the sac, the scrotal sac. So the gubernaculum attaches this testis to the kind of like the skin. And this is majorly implicated in testicular torsion. So in testicular torsion, this guy that lies horizontal becomes flat, becomes horizontal instead of being vertical. And so there's a weakening of the gubernaculum. The gubernaculum that's supposed to attach this guy here, right, is weakened. It's not holding it in place. And so the testicle can assume this horizontal position, right? And this gubernaculum is what gives rise to the round ligaments. So in females, it degenerates rather. In females, it degenerates to form the round ligaments and the ovarian ligaments, right? Ovarian ligaments, right? Because I was trying to tell you guys that when the paramesonephric duct degenerates, there'll be a space between the the head of the paramesonephric duct and the ovaries, and you need something to suspend it, and that's where this thing comes into play, right? Do you have any questions so far, so that I can know whether we are following? Any questions? Okay, so that being said, the next thing we want to talk about basically is the drainage of the. So I want to draw a diagram for you guys. Sorry, I started late. That's the problem. If I had not started late today, would have covered so much, right? It's almost done with the class. It's an hour. It's an hour's class, hour and some minutes. It's supposed to be 2 hours, but you guys have your UWorld session, and I don't want to kind of like interrupt that. So what I wanted to draw for you guys basically is this. All right. This is the ovaries. This is the fallopian tube, right? And then this is the uterus, right? And this is the cervix, endocervix. This is the vagina. Right? This is the vulva. This is the vulva out here. So I'm going to use this to kind of like explain the histology, and then also explain the kind of like the lymphatic drainage of the female reproductive tract. I'm going to use this to kind of like explain it. So I'm going to kill two stones with one bird, right? Kill two birds with one stone. So basically, the ovaries. Let me start with the drainage. The ovaries, the lymphatic that drain the ovaries, drains into what we call the para-aortic. So I usually call it A. Right? I usually call it A. So the next thing is here, the uterus is an E. And so usually I just label it like this, try to kind of like try and avoid confusion. The cervix is I. And the distal vagina, from the distal vagina to the vulva, is the inguinofemoral nodes. So this region between the upper cervix, this region here, is supplied by both. But the inguinal node drains the upper cervix, the upper part of the vagina and the cervix, the inguinal node. The external iliac node drains the fundus, the cervix, this whole region here, right? The aortic, para-aortic. So this is the para-aortic. The A is the para-aortic. The way to kind of like remember the lymphatic channels, right? The E is the external iliac. So this is the external iliac node. Iliac. The I is inguinal. The IF is inguinofemoral. So a way to remember the nodes basically is that when you draw this diagram, it's very easy. You just have to know how to label it. The ovaries is the A, which is the para-aortic. The fundus of the uterus, the body of the uterus, is the external iliac. The middle, this middle part here, you can also say it's drained by the internal iliac before the inguinal lymph nodes. And then the space between the upper cervix and the distal vagina, this part here, is a combination of both the inguinal and the inguinofemoral, right? And the vulva, the distal vagina, all as drained into the inguinofemoral nodes, right? So this is a way to also kind of like remember the nodes that are involved. Now, to remember the histology, basically, I want you guys to remember that this side here, right, is the hardest part of like kind of like this, the side that is exposed to the most friction. And so the epithelium that's supposed to be here the epithelium that's supposed to be here will be an epithelium that can withstand abrasion. Hence, it will be keratinized. So what we have at this point here from this vulva, the vulva here, this vulva here, is keratinized squamous epithelium. When you now get into the vagina, all the way to this ectocervix, here, so from this point here, what you now have is non-keratinized, because of course it's exposed to friction, but not as much as the vulva. So non-keratinized. Non-keratinized squamous epithelium. Now, what happened? What do you have in the uterus, basically? In the uterus, the epithelium you have here is something, is something that it's supposed to be long, right? And the reason why it's supposed to be long is so that it can trap the ovum when it is fertilized and hold on to it. And so what we have here is simple columnar epithelium. But now, what epithelium will we have here? That's the question. That's the three question. Now, this is the fallopian tube. When the ovum is released, you need something that will propel it into the uterus. And so you need something that can have finger-like projections, right? That can help to propel it. And so what you have here is simple ciliated. Simple ciliated. While the ovaries is just simple cobodium. So that's like the logic I used to kind of like remember the epithelium. And so in a question, they tell you that they take a biopsy of any of these regions, and then you start seeing cilia. Once you see cilia in the question, just know that you are in the fallopian tube, that the biopsy was most probably taken from the fallopian tube. Okay. Do you have any questions here, guys? Any question at this point? Do you have any questions? Do you have any questions at this point? Okay, so I said that let me show you this diagram so that you can understand. So I said that the part that has the most friction is the vulva. Vulva is the side that's exposed to a lot of friction when women wear their pants, or when they want to urinate, when they want to wipe their, their private parts, if they are done urinating, it goes through a lot of friction, and thus it has to be keratinized. So the vulva is the most keratinized, so that's the only part that has keratinized squamous epithelium. But when you start from the distal vagina to where the ectocervix is, the patient still has squamous epithelium, but that part is non-keratinized. That's what I was just trying to say. That's what I was just trying to say there. Okay, so let's go on. Or should we stop here, guys, for tomorrow or next on Monday? Yes, on Monday. Should we stop here till on Monday, or you want us to go further? I think you guys have your U-Word session.
Doc, could you please explain the lymphatic drainage again?
Okay, so let me go over that again. So the lymphatic drainage, I label it. So let me do this, right? So the lymphatic drainage, right? What I was just trying to say is, let me explain this again. So let me just explain this quickly so that you guys get the logic, right? So I said that the aorta, I usually just label it. Sorry, the ovaries, I just usually just label it as an A, the ovaries and maybe the testes, right? I label it as an A. This A stands for para-aortic. Right? And then this whole region here that you're seeing to the uterus is drained by the external iliac. So I label it as an E. And then what I now do is that, and I'll say that this region here, between this region that stops the upper body of the uterus and then the lower body of the uterus, just where it meets the cervix, right, is the internal iliac. And then this cervix region to this lower part of the proximal vagina, I label it as another I, right? Or rather, I label it as, this part here, this part to this lower part of this vagina, I label it as an I, which is inguinal, right? And then I just put a plus here, a plus. And then this lower part here to the vulva, this distal vagina to the vulva, I label it as IF. So let me go over it again so that I kind of like explain what I did. So the aorta kind of like takes the para-aortic lymph node, drains the ovaries, and then from the ovaries, from the fallopian tube down to the upper part of the body is drained by the external iliac nodes. And then I said that from that upper part of the body to kind of like the proximal part of all, let's say the endocervix, right? From this body to the endocervix, I said it's called the inguinal. And then from this point here that I mentioned, from this ectocervix, right, to this middle point here, just a little bit above the distal vagina, is a combination of both the inguinal and the inguinofemoral. And then the lower distal vagina and then the vulva drains into the inguinofemoral. So this middle part here that I are seeing, that's between the proximal, the endocervix, and where the ectocervix ends, between the ecto and endocervix, drained by both of them. And then the distal vagina and then the vulva is drained into the inguinofemoral. I don't know if that makes sense.
Yes, it does. Thank you.
Okay. All right. So do you guys want me to stop here so that you guys can like have your UWorld session? Okay. So I'll see you guys on Monday. We're gonna continue. I wish I could do pathology with you guys today. I was almost close to pathology, but the time is. Oh, thank you, Dr. Jamil. Thank you, Dr. Jamil. So let me allow you guys to read and kind of assimilate what I've taught you guys.
Doc, is there any way you have an input on the recordings? Because we don't have any of the recordings. Like when you went through the slideshow, we don't have access to those recordings.
Well, you don't have access to the slideshow recordings.
No, we missing plenty of the recordings.
Oh, I would have to tell Dr. Ahmed about that because currently now it's even recording, but I'll have to tell him to send you guys. I thought he had. Wow, I thought he sent that. I thought he sent a playlist that had almost all the videos I did.
So that's a playlist one of the students in the class put together. I think Dr. Eileen, and that only has about 6 recordings, and by now you've probably done like 12 or so.
Okay, so I'll have to tell Dr. Ahmed about it so that he can kind of like rectify that, right? I'll talk to him and see.
The first 5 recordings are when he started the sessions, because he did 5 sessions first. So those first 5 are him. And then the next 5 are you. And then he just posted 1 recording today. So that would make 6 of your recordings, but there are much more still missing.
Okay, so I will have to tell Dr. Ahmed to rectify that. I'll chat him up immediately after this class so that he can drop them. I thought he did because I saw a playlist where they were like, but I'll tell him to do that. I'll tell him to do that.
Yeah, so probably what you could do is you could probably go through the playlist and see which recordings are there from you and then make a determination as to what's missing because you know what you taught. So
Okay.
you'd be able to determine to say, okay, this particular topic is missing or this section is missing. Let's try and send that one.
Okay. Okay, I'll do that.
Okay, thank you.
Yeah. Okay, so let me allow you guys to get to your reward session, and then we'll do that.
Thank you, Doc.
Yeah, you're welcome.
Thank you, sir. Thank you, Rob.
You're welcome.